Good afternoon to everyone. It's a pleasure to be here at the national, this NUDS, and we have with us Dr. Biswajit. I'm Dr. Rakesh Sahay. I'm an endocrinologist, professor of endocrinology at Usmania Medical College in Hyderabad, and I have with me Dr. Biswajit, who's the additional professor and head of the Department of Oncology at the JIPMER Pondicherry, and he's a very eminent endocrinologist. He has had several publications in the field of oncology. He's a brilliant oncologist who's going to speak to us today about the relationship between diabetes and cancer. So I would like to ask him a few questions. I would start off by asking him, what is the relationship between diabetes and cancer? Dr. Biswajit.
Thank you, Dr. Rakesh, and good evening. Diabetes and cancer has been very interesting relations, and we have over a period of years we have seen that we see patients with cancer patients who come with diabetes, and we have issues related with management and treatment specifically with them. So it has long been debated whether diabetes causes cancer, and we have some evidence from a lot of epidemiological studies that a particular set of cancers are supposed to be higher in patients who have diabetes. And so the cancers generally are driven by the endocrine hormone related cancers are the ones which are generally seen. And these cancers are breast cancer, endometrial cancers. In breast cancers, it's generally the postmenopausal group of patients. And then you have this GI cancers, which are colorectal malignancies, and the hepatobiliary malignancies, which is the hepatocellular carcinomas and the pancreatic carcinomas.
Thank you, Dr. Biswajit. What I would like to ask you, Dr. Biswajit, is that you've clearly told us that there is a clear relationship between diabetes and cancer. That we see a lot of our patients with diabetes developing cancer. So sometimes we are sort of thinking whether diabetes does cause cancer or not. So can you tell us what are the mechanisms by which diabetes can increase the risk of cancer?
Right. So I think what we must understand is there are many factors which are common to both diabetes and cancer. And it is not only the direct relation between diabetes causing cancer, but also the other related factors. And the other related factors is mainly obesity. And we know that obesity, the insulin resistance is patients who have obesity, there is a high risk of insulin resistance in these patients. And insulin resistance is one mechanism by which probably cancers can occur. And the mechanisms by which generally it occurs is by what is called as hyperinsulinemia states in these situations. And these hyperinsulinemia states generally activate this IGF, that is the insulin glucose receptor factor receptors. And these IGF receptors are known to cause proliferation of cells. And we know that if the proliferation of cells occur, then there is an increased chance of mutations, and that leads to cancer. So that's one mechanism which has been described. The other mechanism is the chronic disease and the chronic inflammation which is associated with cancer and the diabetes. And some of those chronic inflammation syndrome, which actually releases some of the cytokines like the interleukins and the TNF alpha, are related both are seen both in cancers as well as in diabetes. So, and there are mechanisms by which all this cause DNA damage, and drugs which also could result in anti-diabetic drugs which could result in malignancy. So these are some of the mechanisms by which.
Yeah, thank you, Dr. Biswajit. What I could understand is that there are at least 4 different mechanisms which you have highlighted. One is because of the fact that we know that most of our patients with diabetes, particularly the obese ones, are the ones who have insulin resistance. They have a higher amount of insulin being secreted to produce the same effect on glucose metabolism. While the glucose metabolism is okay, with the high insulin level, but the high insulin level has other effects on the IGF-1 receptors and also through the other pathways like the MAP kinase pathway, and then it leads to proliferation of cells. So that is one thing you've clearly told us about. And you also told us that there could be just the fact that obesity and diabetes correlate, so coexist. So obesity and diabetes also being an inflammatory state, you said that there could be all these inflammatory mediators which could be mediating the development of cancer. And the third mechanism which you said was that hyperglycemia itself can be toxic to the cells and can induce cancers in certain cells. And I think the fourth mechanism which you were highlighting was that anti-diabetic medications can sometimes promote cancers. So let us discuss each of these things. What I would like to, before we go into each of these aspects, I would like to ask you about, what are the specific types of cancers you think are increased in diabetes, and do we need to screen individuals for these cancers? All our diabetic patients, do you think we need to screen them for these cancers?
Yeah. So as we were discussing that one is the hormone-driven cancers, and that is the breast cancer and the endometrial cancers. And then you have the GI cancers, which are the pancreas, hepatocellular cancers, and colorectal malignancies. So these are the malignancies which the incidence is almost twice than in the normal population when compared to patients who have diabetes. With regard to screening, I'm not sure we have enough data that we are particularly targeting diabetic patients and screening these malignancies. Screening programs are available for breast cancer. That is among these 5 malignancies, we only have well-defined screening program for breast cancer with mammogram, and the screening starts at 40 years of age. But generally, diabetes itself is not considered as a risk factor for screening. So this is an interesting area. I mean, we need to work on it. I'm not sure there is enough data for it, but whether patients who are having diabetes, we should start screening much earlier than the routine mammographic screening, which starts at 40. But unfortunately, the other malignancies like endometrium and other GI malignancies, we anyway do not have a very good screening program as such.
Yeah, I think because we have, I mean, I think between in different ethnic groups, there's a differences in these types of cancers. And although, as you said, that the GI malignancies are probably twice as common in patients with diabetes, but probably I don't think we have enough data from our country to suggest that we need to screen all our diabetics for these patients, for these types of cancers, because in some I'm aware that in some ethnic groups it is recommended that the screening for GI malignancy is done more routinely as compared to our population. So probably I think we need to have more data on our diabetic patients. We need to follow them up, see what are the malignancies, particularly look for these malignancies, and then devise screening strategies. What I would like to ask you is that does the presence of diabetes have an impact on the management of these cancers? Do you think you would change the management based on the diabetic status, or does that have any other impact on the management issues?
So I think that's a very important question, because almost 20% of our patients, especially patients presenting above the age of 60, we generally see diabetes coexisting with cancer patients. And when we need to start treatment, then that is the place where it makes a major difference. So how it influences our management is let's say when we are giving chemotherapy, we use antiemetics, and the antiemetics includes steroids. And if patients who are diabetic, then we need to regulate those anti-diabetic medications better. Otherwise, they'll end up in uncontrolled hyperglycemia. The second group of patients is when we give some drugs as infusion, they develop infusional reaction. And to prevent these infusional reactions, we use little high doses of steroids. And classical example is when we use a drug called paclitaxel or a docetaxel chemotherapy. These are the chemotherapies where we probably need to give almost 24 milligram of steroids over 3-4 days. And if the patient is a diabetic, then it obviously affects the hyperglycemic control. So in that situation, new drugs have been coming up where you use liposomal preparations to prevent this infusional reactions, and you can actually avoid giving steroids for these patients. So that is one set of patients. The other set of patients are patients with acute leukemia, where we give a lot of steroids during the initial part of the treatment as a part of anti-cancer treatment. They almost receive steroids almost of 60 milligram of prednisolone on a daily basis for a month or to 45 days. And we see again in the young adult and in the elderly population, when we give the steroids, then they go into a state of hyperglycemia, and then the control of sugars and all becomes difficult. And these are patients who are not even diabetic. They just could be non-diabetic patients, and just because of the steroids which we give, they go into steroid-induced hyperglycemia. Other set of patients are the targeted chemotherapy drugs, which currently we have. And some of these targeted chemotherapy drugs like the PIK3CA inhibitors, some of these drugs itself can cause hyperglycemia. And one of the commonest drug which we use is a drug called alpelisib. And this drug causes hyperglycemia as one of the major side effects. And you cannot use insulin in this subset of patients because they are all insulin resistant. When you give the drug, then you cannot use insulin for treatment of this hyperglycemia. And we probably have to use metformin for treatment of these patients. There are also other tyrosine kinase inhibitors like nilotinib, which is used for chronic myeloid leukemia, where patients can develop hyperglycemia. There's other set of drugs which is immunotherapy drugs, which target most of the endocrine systems, and one of these systems are probably to develop diabetes. So there are drugs, and we need to manage the side effects and get the sugars under control. And we also know that if the sugars are uncontrolled and you have cancer, the risk of mortality is also high. And the risk of mortality is high because of multiple reasons. And one of the reasons could be just the sugars are so high that your sepsis, chances of developing sepsis could be high, or just that uncontrolled hyperglycemia infection also can result in other cardiac abnormality, cardiac morbidity, and the patient may have increased mortality.
So the other aspect that I would like to ask you is that does diabetes itself, I mean, does it sort of influence the response to the chemotherapy? Because the fact that a person is diabetic, because you have shown us that clearly that many of the medications that are used are going to cause hyperglycemia, and there's a frequently need for steroids, which will increase the hyperglycemia. Then I think you have spoken about the new immune checkpoint inhibitors also that cause development of type 1 diabetes, particularly in many patients. But does the presence of diabetes also have an impact on the outcome of the treatment?
So I'm not sure if the diabetes as a direct factor causes an influence over the treatment outcomes, but it regulates in the form of, I mean, either your glycemic control is out, and then your chances of developing infection and mortality. So as directly, just because hyperglycemia alone directly causes, I mean, worsens the outcomes of cancer, I'm not sure the data is available for that.
Yeah. Another interesting point that I would like to ask you is that does while we said that most of these cancers are increased in patients with diabetes, would good control of diabetes, we know that good control of diabetes prevents the microvascular complications, to some extent even the cardiovascular disease. Do you think these cancers can also be prevented, or they are, I mean, or diabetics are destined to develop these cancers?
So I think one thing is clear is that just the control of sugar alone may not be enough. So the result is because of the factor of obesity and the insulin resistance. So once we target the factors which will affect the insulin resistance, probably that may make some effect. But just the sugar alone control, I think, will not make a difference in your outcome.
So I think it's not just the glucose value, but it's also looking at optimal management of the weight, and also optimal management of insulin resistance, so as to sort of get the long-term benefit. But we don't have any data to show this this sort of a benefit, because nowadays we are in a evidence-based era, and we look at clear evidence. I think it will take time before we can generate such an evidence to show that the cancers can also be reduced. Now, the other interesting aspect is about the anti-diabetic medications and their propensity to sort of increase the risk of cancers, or reduce the risk of cancers. So, what would you say about these agents, particularly metformin? Metformin is a very versatile drug which we use it in most of our patients with diabetes. So, what's your view on metformin?
So I think the drug metformin in 2010-12, when we had this strong meta-analysis with retrospective data showing that diabetic patients who are on metformin had a protective and better, I mean, protective as well as a good outcome with respect to cancer. And from there have been a lot of prospective kind of studies where people have tried using metformin along with chemotherapy and see whether the response rates as well as the survival improves with adding on metformin. There is a lot of basic science research work done on metformin saying that the metformin works through a particular pathway, it prevents and yeah, so it has yeah, correct. So we have data for metformin working in that. Lots of basic work has been done, but when prospective studies have come, we have not seen that kind of real evidence to say that the response rates as well as the survival is better. But in medical practice, I mean in our practice, if somebody has malignancy, if you are given a preference between using let's say insulin versus using metformin or any other drug like pioglitazone or any other of those anti-diabetic drugs, still metformin would be a choice because we have some basic evidence to say that that is a protective effect.
There was incidentally there was a, I mean, although we know that all the data till now has been showing that metformin has got anti-cancer effects, but recently there was a lot of hue and cry because some of the metformin preparations which were banned by FDA because they had some carcinogenic contaminants in that, some of the carcinogenic contaminants, particularly in the sustained release preparations, and not in the not in the immediate release formulations. What about the glitazones? What do you
Yes.
say? What would you like to tell us about
The evidence is very, I mean, you don't have real hard evidence, but except for one drug, the pioglitazone, where bladder cancer and pioglitazone uh, has been linked for a long time. But beyond that, my knowledge is also not. I mean, I
yeah,
don't.
but I think the subsequent, I mean, there was a little bit of a risk shown in the earlier studies, but after that analysis of larger data sets has clearly shown that that this relationship does not exist, and pioglitazone probably does not increase the risk for bladder cancer. And then we have the gliptins or the GLP-1 analog, which both work through the incretin pathway. So there again, we are a little scared about pancreatic cancers.
Right.
But what is the evidence? Do you think there is any evidence
So again, there's
suggesting?
a lot of animal model studies and basic science research happening where they say that what these drugs cause increased secretion of this insulin from the ducts of pancreas, and then that results in pancreatic cancer and have some pathway linked to the chronic pancreatitis and obviously and developing diabetes and malignancy. Again, not very strong evidence, but there are some animal basic research
Yeah, so
data.
I think again, I think all the data that is available does not suggest any increase in the risk of pancreatitis or development of pancreatic carcinomas with the gliptins, either the gliptins or the GLP-1 analogs. But I think we avoid using them whenever there is a history of pancreatitis, chronic pancreatitis, or in such situations we generally tend to avoid using them because that those are scenarios where we are probably going to increase the risk. And I think with the SGLT2 inhibitors also, this is a new class of drugs which have been shown to have the cardiovascular and renal benefits. But again, I think there is no clear-cut evidence to say that they are protective against cancer, nor are they increasing the risk. Although there was initially, just before DAPA was introduced, there was a little discussion about whether it increases the risk of bladder cancer, but that was not substantiated in any study. And similarly, we don't have any clear data on SUs, the sulfonylureas, which have been again medications have been used for a long time. Finally, I would like to ask you before we close. I think we are running out of time, but I would like to ask you about: is there any clinical or biochemical marker to guide us regarding regarding which is going to sort of alert us towards development of cancer in any of our diabetic patients? Do you think there's any such marker that can be measured or?
I think the clinical markers, obviously, the most important would be the obesity, and the marker would be looking at a BMI. That would be a clinical marker. And obviously, a biochemical marker would be something like obviously the hyperinsulin. If you are measuring the insulin levels and the insulin levels are very high, and that could result. The other set of patients, which I don't know whether we could call it as a marker, but women with non-alcoholic steatohepatitis, NASH, and there is some evidence to say that there is a direct relation between NASH and development of cancer, and that increases. So whether that should be a focus of, I mean, you screen those patients for NASH and C. I think it's basically the lifestyle modification which is important to target. Obesity, your sedentary lifestyle, these are the factors probably.
So thank you, Dr. Biswajit, for the very wonderful insights that you've given. I think the important message that we are giving is that again the clinical views, a clinical examination, clinical management of patients is very important. Look at obesity, try and look for signs of insulin resistance. Those are all indicators of and the presence of non-alcoholic fatty liver disease, as you said, is again a marker of insulin resistance, and that can be related to some of the cancers. And presence of obesity and other signs of insulin resistance are important markers towards subsequent development of cancers, and we should address them effectively with lifestyle measures and optimal use of medications so as to sort of holistically manage diabetes, not only looking at the glycemic control, but also these parameters to be well addressed. Thank you, Dr. Biswajit. I think we had a good, insightful discussion. Thank you.
Thank you.